I hope my slides are visible.
Yeah.
So, warm regards from Disha Eye Hospitals in Kolkata. I'll be speaking on the enigma of similarity. Does randomized control trials translate into real-world practice? So until 2006, many of our neovascular AMD and DME patients actually had only progressive vision loss to look forward to, and these patients had a lot of anxiety, confusion, fear, and shock. The breakthrough actually came in the year 2006 when ranibizumab was approved for usage in neovascular AMD. If we look at the evolution of ranibizumab, starting from neovascular AMD in 2006 and retinal vein occlusions and diabetic macular edema in 2011, it also received approval for myopic CNVMs in 2014 and recently, of course, for retinopathy of prematurity. Now, in between, we had something that happened in India, that was the approval for the biosimilar ranibizumab in the year 2015. Now, what it meant for retinal therapy and treatment options was that be it neovascular AMD or diabetic macular edema, retinal vein occlusions, or myopic CNVMs, a lot of these patients could be treated and vision could be improved with anti-VEGF agents. Also, steroids do chipped in, and lasers were essential in certain situations, and vitreoretinal surgery in certain scenarios were necessary. So what actually changed since then is that there has been a 46 to 72% reduction in blindness worldwide across various retinal diseases. Most of this is based on the consistent 12-month visual acuity gains with the innovator ranibizumab in the treatment of retinal diseases, be it neovascular AMD or diabetic macular edema or the retinal vein occlusions or myopic CNVMs. These patients actually have gone on to improve vision. And what is even more important is that once the vision is improved, you can actually go on to maintain this vision long term with what these studies have shown us. However, when it comes to the real world, things might be different. Randomized clinical trials are interventional and comparative data. They have specific well-defined patient inclusion criteria. Good patient adherence and compliance is a foregone conclusion, and one can assess the efficacy, posology, and safety in the patient cohort. In the real world, the studies are usually open label. They are representative of a broader patient population, have variable patient adherence and compliance, and of course, one can assess the performance in routine clinical practice. Regarding comparing different anti-VEGFs in neovascular AMD in the real world, probably the largest data set comes from the IRIS registry, where we have seen 3 anti-VEGF agents being compared head-to-head in neovascular AMD in 1 year in the United States clinical practice. So lots of injections. What is most interesting is that all the 3 agents that were used, bevacizumab, ranibizumab, and aflibercept, required similar number of injections at the end of 1 year. And if you look at the visual acuity improvements, ranibizumab and aflibercept, the approved agents, actually had similar visual acuity improvements compared to bevacizumab, which slightly lagged behind. But what about comparing with biosimilars? Well, the RENEX study was there, of course. It was retrospective, multi-center observational study, but the study was actually for a duration of 3 months only, and it was a non-inferiority study, meaning that actually they looked into percentage of patients with loss of less than 15 letters. And of course, the study had only 100 patients, with 75 in the biosimilar arm, and the innovator ranibizumab had 25 patients. So we did the study across 15 branches of Disha Eye Hospitals, 5 urban and 10 rural branches. We compared innovator ranibizumab versus the biosimilar ranibizumab in treatment-naive wet AMD patients across multiple centers of Disha Eye Hospitals. This was non-randomized, retrospective, open-label, phase 4 multi-center study of 900 odd patients, where the innovator ranibizumab had 726 patients and the biosimilar group had 177 patients. And the objective was to evaluate change in visual acuity with the innovator ranibizumab and the biosimilar ranibizumab in neovascular AMD patients. If you look at the inclusion criteria, of course, these were treatment-naive patients. At least 6 months of follow-up was necessary, and both eyes could be included as separate cases. Regarding exclusion criteria, no switching of drugs was allowed, and any other coexisting retinal disease or surgery, the patients were omitted from the analysis. Besides the primary endpoint of change in best-corrected visual acuity between baseline and final follow-up, the secondary endpoint we looked at was the number of intravitreal injections that the patient received. Moving on to the results, For patients who had 636 or better visual acuity, that is converted to logMAR, it was 0.75 logMAR units roughly. The innovator ranibizumab group had 0.201 logMAR units of improvement compared to the biosimilar group, which had 0.078 logMAR units of improvement. Now, this difference was statistically significant in favor of the innovator ranibizumab group. Moving on to patients who had less than 636 vision, here the difference was even better for the innovator ranibizumab group with 0.304 logMAR units of improvement that was noted for the innovator group compared to 0.133 logMAR units of improvement for the biosimilar group. Again, this difference was statistically significant in favor of the innovator ranibizumab molecule. What about patients who improved 3 or more lines? Well, for patients who had 624 baseline vision, the innovator ranibizumab group patients had improvement of 3 or more lines in 48% of the patients. Almost half of the patients improved 3 or more lines compared to 29% patients who actually improved 3 or more lines on the biosimilar ranibizumab. So this difference again was statistically in favor of the innovator ranibizumab group. And regarding adherence to treatment with this, that is treatment continuing with the same anti-VEGF molecule, for the innovator ranibizumab group, it was 23% of the patients who continued with the same anti-VEGF molecule compared to 6.8% of the patients who compared with the same anti-VEGF molecule for the biosimilar group. So there was a threefold difference here that was statistically again in favor of the innovator ranibizumab group. Now, if you talk about mean number of injections, remember this is neovascular AMD we are talking about. The mean number of injections for the innovator group was 2.1 injections compared to 1.56 for the biosimilar ranibizumab group. Again, this was in favor of the innovator molecule. And regarding patients who took actually 3 or more injections in the innovator ranibizumab group, it was 30% almost, that is 29.7% of the patients receiving 3 or more injections of the innovator drug compared to 16% of the patients receiving the biosimilar drug. So again, this was statistically in favor of the innovator molecule. So in a nutshell, the evidence from randomized controlled trials probably do not fully match with the real world data as far as our data is concerned. Improvement of visual acuity in the Indian context may be more than what we have seen in the West. And of course, drug cost may not be the only factor that drives compliance. Moving on to the DME part of the study, although we know that anti-VEGFs is the mainstay of treatment, and probably it would be best if all of the patients could afford the approved treatment, that is Eccentrics, for the center involving DME cases, but maybe cost is a factor which do not allow full treatment with Eccentrics or the innovator ranibizumab molecule in all these patients. But is cost the only issue here? Let's look at what this data has to show us. So again, this was innovator ranibizumab versus biosimilar ranibizumab. This was non-randomized, retrospective, open-label, multi-center phase 4 study of 1,600 odd eyes, where the patients actually presented with center involving DME. These were again treatment-naive patients across multiple centers of Disha Eye hospitals, and 17 ophthalmologists were involved here. The innovator group had 1159 eyes, and the biosimilar group had 464 eyes. Again, the objective was to evaluate the change in best-corrected visual acuity between the innovator ranibizumab and the biosimilar ranibizumab in diabetic macular edema patients. Similar inclusion criteria, these were of course diabetic patients, had to be adults of course, and they had to be treatment naive, and both eyes could be included as separate cases. No switching was allowed, and any other coexisting retinal disease, or if the patient underwent any kind of ocular surgery, these were excluded from the analysis. So here, if we look at patients who had 636 or better vision, then the improvement was 0.201 logMAR units, that is Snellen's converted to logMAR scale, and that was the improvement for the innovator group compared to 0.137 logMAR units of improvement for the biosimilar ranibizumab group. Now, this difference was again statistically in favor of the innovator molecule. Regarding patients who had lesser visual acuity, that is 636 or less, that is converted to the logMAR scale, 0.75 roughly. So here the improvement was 0.299 logMAR units of improvement for the innovator and 0.191 logMAR units of improvement for the biosimilar molecule. Again, this was statistically in favor of the innovator molecule. Regarding patients who improved 1 or more lines, remember this is DME of course, for the innovator ranibizumab group, 70% patients improved 1 or more lines, and the biosimilar group, it was 53% of the patients who improved 1 or more lines in DME. Now, regarding adherence to index treatment, that is the same injection being continued for more than 6 months, it was 13% for the innovator group compared to 6% for the biosimilar group. So we see a twofold difference here that was there in the adherence. Regarding the mean number of injections for DME, the innovator group, it was 1.63, the mean, and 1.34 was the mean for the biosimilar injections. So again, this was statistically in favor of the innovator molecule. Regarding the percentage of the proportion of patients receiving 3 or more injections, for the innovator ranibizumab group, it was 15% of the patients who received 3 or more injections for the DME, and for the biosimilars, it was 7%. So a twofold difference was noted here. Regarding limitations of our study, as like all real-world studies, due to pre-specified criteria, data from only a subset of eyes could be included. The visual acuity was, of course, recorded in Snellens and then transferred to logMER for statistical purposes. And this being a real-world study, mostly a PRN regimen was used for this. However, if we look at our attrition rates, they are similar when compared with other cohorts of real-world studies that are published in literature with reported losses between 55 and 89%. But when it comes to improvement of visual acuity in diabetic macular edema, we are not alone. The Luminous study actually has shown that in treatment-naive DME patients, you can actually have improved visual acuity with a low number of injections. The other important thing that I need to mention here, I thought, was that in a study of Medicare claims data from 2008 through 2010, the mean number of claims per year for the number of bevacizumab injections was 3.1 to 4.6. Meaning thereby that something that is relatively inexpensive as opposed to the approved agents does not necessarily drive up numbers sky high as far as injection rates are concerned. But we actually wondered after seeing the results, why was the better adherence for the innovator molecule? Was it the better visual acuity outcome or the better safety and tolerability, or whether it was patient counseling that did the trick as far as the patients were concerned? And from the physician's perspective, was it the treatment assurance that could be provided for the innovator molecule or the proven track record of the innovator molecule that actually, tilted the balance in favor of the innovator? But in a nutshell, what we note is that visual acuity improvement is significantly better with innovator ranibizumab as compared to the biosimilar. Patients on innovator ranibizumab have 2 to 3 times significantly better adherence as compared to the biosimilar, and real-world evidence for the innovator confirms the effectiveness observed in randomized clinical trials. I'd like to thank you all for your kind attention.